the dragons. Off you
Thank
go.
Thank you, Grégoire. So it's my pleasure to present you the APIxaban study on behalf of my co-PI, so Jean-Luc Bosson and Marie-Antoinette Seves from the French Innoviti network. So Grégoire, like me, from the CAN Vector network, and Marc Rigini from Switzerland. So the APIxaban study focused on the management of isolated distal DVT, which are infrapopliteal deep vein thrombosis without pulmonary embolism. And it is the most frequent clinical presentation of the venous thromboembolic disease. It represents more than half of all isolated deep vein thrombosis. At variance with some guidelines that do not suggest to treat them with anticoagulation, in routine clinical practice, distal DVT are almost systematically treated with anticoagulant. Why? Because patients are symptomatic, they know that they have a DVT, so they are worried and they expect some kind of treatment. Furthermore, most family physicians do not accept that their patients are left untreated. The optimal anticoagulant treatment in this setting is uncertain. In guidelines, when anticoagulant is considered, therapeutic anticoagulation is suggested. But what we learn from registries is that in routine clinical practice, various anticoagulant intensity are used. In our Cactus trial, as compared with placebo, therapeutic anticoagulation was associated with less VT recurrence and extension, but clearly much more major bleeding. So the clinical question is, could lower than therapeutic dose of anticoagulant achieve a better benefit-risk ratio than therapeutic anticoagulation in patients with isolated distal DVT? The study will be a multi-center, open-label, assessor-blinded, non-inferiority study. The patient population will be patients with acute, symptomatic, isolated distal DVT without cancer or calcification involvement, because we know that those patients require therapeutic anticoagulation. Inpatients are eligible if their expected date of discharge is less than 6 days post-randomization. So it means that our patient population target more than 75% of all isolated distal DVT seen in routine clinical practice. The intervention, after a 1-week course of conventional APIxaban 10 BID, patient will receive either APIxaban 2.5 BID or APIxaban 5 BID for 3 months with 2 follow-up visits at 3 months and 1 year. The primary outcome will be a composite of VT recurrence, major and clinically relevant non-major bleeding at 1 year. The sample size, 1,300 patients, and the study will be conducted in 25 centers across Canada, France, and Switzerland, but we would be delighted if other countries are willing to join us. So the APIxaban study is a pragmatic study addressing the management of most isolated distal deep vein thrombosis. So the study should be completed in 5 years, including a 36-month period for patient recruitment. How we will interpret the result of the study? If APIxaban 2.5 BID is non-inferior to APIxaban 5 BID, it will avoid patients to be unnecessarily treated with high dose of anticoagulant. If APIxaban 2.5 is not non-inferior, then this will unquestionably validate the fact that most patients with distal DVT should be offered therapeutic anticoagulation. So the APIxaban study is a potentially practice-changing study. So the protocol has been finalized and validated by all co-PI. The study has not been funded yet, but we plan to apply to national institutional grant agencies this fall. The Invent Grant Fund will be exclusively used to help grant submission in each participating country, to facilitate the expansion of the study in other countries, and to strengthen scientific collaboration via funding of a part-time research coordinator and organizing fund conference. So the APIxaban study is critical given the prevalence of distal DVT and the need for a consensual therapeutic management. The Invent endorsement and funding are key to successfully complete the APIxaban study via the promotion of the study by Invent Council members in their respective country. And for sure, this will help strengthening and it should ensure the success of our grant applications in each of the participating countries. Thank you very much for your attention.
Thank you, Jean-Philippe. Dragons, up to you.
I have a comment. First of all, formidable Jean-Philippe, and a nice follow-up to the cactus study program. This sounds like a very expensive study, and I'm a very stingy dragon. I don't like to spend my money. So I'm wondering, given how easy it is for a physician just to prescribe a standard dose anticoagulant for CAF DVT, how convinced are you that the bleeding rates will be lower with a reduced dose anticoagulation? Do you have any information based on the literature that you know of?
Yes, so clearly, first of all, regarding the budget of the study, it won't be that high because we plan, because we will do like for the COBRA study. So we will randomize the patient, and then we will give a prescription to the patient of either APIxaban 10 followed by 2.5 or 10 followed by 5, and they go to their pharmacy to buy the medication, and they are covered by their local insurance program. So the price of the drug won't be part of the budget of the study. So this won't be an expensive study. So that's the first thing which is important to keep in mind. Second thing, yes, we feel that there is no expected benefit to give therapeutic anticoagulation to patients who have distal DVT without cancer or calcification involvement. So the rate of VT event rate should be exactly the same in both groups. And we know from the studies, the previous study with DOAC, that if you use a prophylactic dose, you will have less bleed. And we have to keep in mind that in our patient population, there will be a patient population of randomized trial. And with our estimates, we will have less bleeding event, but in real life, we have patients which are much older, and for those patients, being on a lower dose will be even more beneficial. So that's why I strongly believe that we should offer to those patients lower dose of anticoagulant treatment, because the expected benefit will be even greater in routine practice. Thank you.
Simon.
Well, first of all, I thought that was a very, very impressive presentation. But unfortunately, I can't be kind to you because having come here in a good mood, Gregoire has basically put me in a bad mood. As you see, he mocked the United Kingdom for coming out of the EU, which, coming from someone who's was described by the president of the USA as a country of cheese-eating surrender monkeys, I felt that that was really rich. So I apologize that I can't be pleasant because he's put me in a terrible mood. Pragmatic question. You're making the assumption that these patients must be anticoagulated. Why not have a third arm in which you are actually doing serial Dopplers for these people and seeing whether these, surely there would be some which may resorb, and you're not exposing them to the risk of anticoagulation?
Because we are not doing that, because in routine clinical practice, what we learn from studies is that patients want to be treated. If patient doesn't want to be on anticoagulation, then they can go for serial ultrasound, but that's another study, and we have data from management study that shows that it is safe, but in real life, that's not what is happening. So that's why, as we know that most patients will be offered anticoagulation, we want to give them the lowest dose as possible.
So I accept that. I accept that that may be what is happening, but actually we shouldn't design our studies or even continue our practice on based on that's what other people do. The whole idea of our research is to actually challenge what is being done. I was impressed that you mentioned that this is what patients want. So I was interested in what patient participation involvement you've had in the design of the study and the workup of it.
So the patient, so we have not included patients for now in the development of the study, but we did it previously with the cactus study, which is a previous study that we did years ago. And what we learned also from the cactus study is that, the cactus study, it was therapeutic anticoagulation as compared to a placebo. And we had big issues.
I do read the literature. Thanks, though, for reminding me.
Yeah, and patients did not want to participate because they wanted to be treated. So we already know that they want treatment.
So you don't feel you need to ask patients any other involvement in this study because you know everything a patient has to offer?
No, because no, I agree that it's important to ask to the patient what they are willing to do. But from our previous study, they already told us, and they will be involved. They will be a patient partner, as in any studies that we do with ScanVector and Innoviti and all the networks. So patients will give us their feeling before the submission to ethics. So yes, the patient will be involved. We have not involved them yet, but this will be done before ethics submission to make sure that we did not miss something important. But as we have the experience of a previous study, we strongly believe that it is relevant and that it should be acceptable.
Well, I disagree with you. I think patients should be involved at the beginning of each study and throughout it. And I think there's a real value there. And I'm sorry that what you learned from the cactus study wasn't that we should have patients involved in all the trials we run. But you know that's for your decision.
I understand, but you have also the discussion that you have with your patient when you see them at bedside, and when you talk with the patient, they tell you first that they want treatment, and when you told them about the dose, they want therapeutic anticoagulation, because it's not. That's from my clinical experience. So from my clinical experience, I've talked with the patient and I've talked about the dose. So on a practical point of view, it's a kind of, my feeling is that it's a kind of involvement. But I agree with what you say, but they will be involved before final ethics submission.
I would suggest to you that whilst this, what you've said there is very helpful when it comes to implementation and dissemination, I believe the patients have a very strong role in actually contributing to the design of the study, how the study is monitored, and also, from my experience, and also the experience of the UK Patient Partners Forum, it actually they'll have some fundamental advice for how to make randomization, how to make recruitment easier based on what they as patients feel. And so I think the advice that you've had from your patients there would also be very useful throughout the design and conduct of the study. Something to consider.
No, but we will ask the patient. We will ask to our patient partner what they're feeling before finalizing all of that. Yeah.
So I hope you had a chance to vote. One last question from Roger. Quick question, Dr. Roger. Quick answer. Oh, Roger. Oh, what's your question? I see you have a question. I can't see it.
In the chat.
In the chat. Yeah.
Oh,
indirect comparison.
It's gone from the chat. I think the question was similar to what I had asked about the data to inform that there might be a difference in bleeding risk between the full dose and low dose APIxaban.
Yeah, so we made our estimate based on the DOAC study and also based on the TICT study, which is an Italian study that had it was a management study, and so there was no comparator, but they had patients on full anticoagulation with low mol for 1 week, and then an intermediate dose for 3 weeks. So then we had an estimate of the risk of bleeding with patients that are fully anticoagulated, then dose reduction.
Perfect. Sorry, we have to move on. Thank you, Jean-Philippe.